So my name is Emeka. Today is our first episode of our podcast, and today we're going to talk about something we've been experiencing and dealing with, and that's hepatitis C.
Not because we have it.
We don't have it. But we are 3 medical students, all from AUC, doing a rotation in the HIV elective. And one thing that we didn't expect to treat or even see or learn about is hepatitis C. So today we're going to kind of discuss some of the things, some of the misconceptions about it, some of the treatments about it, and anything else that's related to it. So first I want to introduce my other 2 colleagues. We have Aki and Ahmed, both from AUC. So can you guys tell us a little about yourself? Aki.
Okay.
Where are you from?
I'm from Chicago. Thanks, Emeka. We're in the same class. We're all in the same class.
Mm-hmm.
From Chicago, went to undergrad at Loyola, went to grad school at Rush. I've been a medical lab scientist for a lot of years, and that's me in a nutshell.
Good stuff. What about you, Ahmed?
I'm Ahmed. I went to University of Toronto in Canada, and then we all met at AUC. Now we're here at Bronx, Lebanon.
Okay, so first, this is to either one of you. Like, what has been the biggest surprise that you guys have noticed from doing this elective out here?
So many people have the HCV in this neighborhood, in this area of New York.
800,000? How many was it?
800,000 people walk around New York City with HCV and have no idea.
I mean, just this clinic alone, our attending, Dr. Perry, said he cured roughly around 260 patients. Yeah. Him alone.
And growing. Yeah.
And this is something that you wouldn't really expect. Like, we don't really talk about it as like such an epidemic here. And one thing that he told us is that the biggest killer of people with HIV is actually hepatitis C, and that's not anything that we've read. We all take step 1. It's not even like a big deal. Like, people just say hepatitis C. Okay, here are the 2 drugs to treat it. Mm-hmm. And actually, let's talk about that. What are the drugs that we've been told that you're going to use to treat it versus like what we've actually seen in practice?
They're wrong. Up-to-date books are out of date.
Yeah. I mean, like, even Sketchy, if you guys watch the Sketchy videos,
Sketchy.
I said the Hep C most commonly treated is interferon and ribavirin.
Right.
And what are the actual treatments that we've seen and we use here?
About 15 years more recent than those. So, like, generations have included things like what?
Mavorite.
Mavorit's the newest one. So going back from that would be Epclusa, Harvoni. I don't remember any of them.
I think those were the main.
Sovaldi as well.
Yeah, Sovaldi.
Mm-hmm.
And there are 6 different genotypes of hepatitis C. So in the past, like, the drugs were kind of based on which type of genotype that you have. But now we have drugs where it doesn't matter what genotype you have. We're just gonna give it to you, and you're gonna feel good about it because you're only gonna have to take it, for 8 to 12 months, and it doesn't matter what genotype you are. So that's one of the things that's pretty cool.
Mm-hmm.
Another thing that I think that we should differentiate, because it's very important, and maybe Aki, you can kind of elaborate on this, is how would you look at lab values and indicate that a person is infected with hepatitis C?
Okay, I'm going to tell 2 stories here because
Okay.
you're a very nice co-host on this show. So hepatitis C is detected with a screening test for Hep C antibodies. Okay, all that means is exposure. Once somebody has a HCV, their antibody test will be positive for life. So the test that we usually really rely on is viral load. We treat based on viral load. We used to do genotyping for drugs that were dependent on that in the past. Genotype 1A was the only one we had to worry about treatments for HLA. But otherwise, it's pan-genotypic treatment now, and everything's fine. We just monitor viral load. Hep B is a different story. This is my second story. Side note, this plug is for the blog link that I have included for this podcast on the blogatory, labmedicine.com or .org. I should know that.
Yeah.
We'll fix that in editing. But my recent post on there with ASCP, American Society of Clinical Pathology, is about HCV and how it's curable. The story goes, I was in a heated debate with you guys the other day about how to detect hepatitis B, and I I pulled my little ASCP card out of my wallet. I said, I bet you on this that it's surface antigen that tells people that they've been vaccinated. Well, I was wrong.
This went on for a week. Let's just say that.
Many days.
many days.
Whatever. Anyway, I was wrong. I don't know why I got it mixed up. You detect vaccination to Hep B with the antibody. Exposure's antigen. We monitor core and HBE for infectious status, but it's watched a little differently than HCV.
Okay. Yeah, so I think the biggest thing to get out of that discussion is with hepatitis B, you're going to see the surface antibody, and you're going to know that, hey, that person's been vaccinated. 1, we have no vaccination for hepatitis C. 2, if you have hepatitis C antibody, all that means is that you've been exposed at some point in your life. And, what percentage of people, Ahmed, if you can answer this, that have hepatitis C antibody positive will just overcome the infection and go from acute to never dealing with it again?
So antibody positive? How about viral load, though? Do we know the viral load?
No, that's not important. What I'm saying, some people clear it, right?
Right.
There's a certain percentage that go to chronic, and then a certain percentage that clear it. Now, do you know what percentage that is?
2%? 20. Or, sorry, I think 20%.
Yeah. So around 20%, about 1/5 of the people that get hepatitis C end up clearing it naturally, and then it's those 80% that go to chronic is what we see here in the clinic, and that we have to deal with. And what are some of the things that can happen if someone goes to chronic and they don't get treatment?
The big thing is HCC, hepatocellular carcinoma. So, and that's the thing that curing HCV is so important because you're preventing cancer. That's the big thing. So, liver cancer is one thing for HCV versus HBV2. They both are at risk for it, but one is a little more directly correlated. So, HCV, no fibrosis, no cirrhosis after treatment, you're fine. If you see, hepatitis B infections, you have to keep monitoring those patients.
I actually had the question about this too. What do you think is the number one cause of cirrhosis right now that you mentioned it?
This is a red herring question. Makes you
Hepatitis
think about
C,
alcoholic.
It's hepatitis C, I thought.
It is hepatitis C, yeah.
It used to be alcoholic cirrhosis.
5 years ago it overtook, and now Hep C is the number one cause of cirrhosis.
I'm sure, most medical students and residents would have said,
Top answer.
alcoholism.
Yeah.
Right? And those are false numbers. It's fake news. But
Your professors are lying to you.
The truth is
Illuminati.
Hepatitis C is real, and it's an important thing to treat. And the biggest thing that I think we've gotten out of this experience is that people just need to know more about this condition, right? I think it's taboo to have hepatitis C. We talked about when we had to go to this clinic where we had a presentation in front of all these people that had hepatitis C and some people that had been cured. What is some of the things that they said and why they have not told anyone that they have it? Can you elaborate?
Oh, the group session.
Yeah, the group session. Remember that?
So pretty much where they felt like society will look down on them and that they're going to be treated differently. The fact that if they have Hep C, people are not going to respect them the same way they would be respected.
It was like synonymous with AIDS.
Yeah.
Oh, I have hepatitis. Oh, you've got AIDS. No, it's the same thing. It's not.
Yeah, they looked at it as like it was almost a death wish. We
Yeah.
had that one individual who began to really not take care of himself once he found out he had hepatitis C because he thought he was going to die, and he kind of just was going down like a dark road. And he eventually found out it is curable, and he's on his last treatment. He'll be done in a couple weeks, and then he just won't have to deal with this ever again. And the person doesn't have HIV like a lot of these other patients do. Like a lot of our patients, almost 50% of them are co-infected with HIV and HCV.
Yeah.
And, so why don't we just kind of pivot? I think we talked about a lot of hepatitis C. Let's talk about HIV and some of the things that we see in our clinic. Do people get Cryptococcus neoformans? Do they show up to that in our clinic?
On the boards.
On the boards. But what do we actually see here in the clinic? We don't see nothing? All right.
Never seen it before. Never heard of it.
Same.
What is HIV? Yeah.
All right. So the HIV, these people just look like us. They look normal.
Oh, right. Mm-hmm.
And I think that's the biggest thing to get out of this. A lot of people still think of HIV as like you're this frail person, or the first person they think about is like Magic Johnson and him being rich so he can afford the treatment, right?
Yeah.
But these are people that don't necessarily come from these high socioeconomic backgrounds, but still they're able to get the treatment, whether it's from Medicaid or whatever, but they're just normal people, just like you and I.
Yeah.
To build off that, I think 2 weeks ago we saw a patient with a CD4 count of 54. 54, and I'm like, how is this person walking right now,
yeah,
man?
No big deal.
No big deal. Everything seemed normal, and didn't worry about it whatsaever too. So
Viral load was controlled. I remember who you talking about.
Yeah, viral load was controlled.
Yeah.
Yeah, CD450.
And you said viral load's controlled. Could you tell our listeners what that really means?
So pretty much viral load means is that the virus is replicating actively. And if it's replicating actively, then it could be transferred to other people. But if you're given medication for it and the viral load is 0, meaning that you cannot transfer the virus to someone else. So when they say that, you probably heard all over the news about PrEP and PEP.
Yep.
Same thing, what they use.
And what do PEP and PrEP mean?
Pre-exposure prophylaxis.
That's
and
PrEP.
Post-exposure prophylaxis.
PEP.
And it's one drug called Truvada. And pretty much it's given to most patients that have any high-risk behavior. You give it to-
Anaphylactically.
anaphylactically, and once they have 0 viral load, they can have sex or the way whatever they want to, and not worry about passing it on to their partner.
Or in some instances now, their child.
Mhm.
They're
Their
using it
child.
as a HIV protective. Yeah.
That's definitely awesome that we have drugs that can lower people's viral load, and that's
Mhm.
pretty much the biggest thing that I've gotten out of this. That you can just take someone's viral load that might be in the millions. If you treat them adequately, it'll get down to 0, and then they can just live a relatively normal life. And what is something that I know we've seen it, these mutations, right? What are some of the things that can happen when someone's not compliant or adherent to the drug regimen? For instance, the individual we dealt with recently with
Yeah.
the colors.
Yeah.
Want to go into that story?
I'll let you go into the story to frame it, but like just as a fact, if a patient isn't sticking to a regimen of medication, isn't adhering to whatever combo or heart therapy or PrEP or Truvada or whatever they're on, they can experience wild type mutations with their HIV. Wild type mutations can lead to resistance, which can lead to drug treatment failing, and their viral load can be uncontrolled, unsuppressed, and their CD4 counts can just plummet. That's when you see the patient on the board question who's got PCP, crypto, toxo, all the things that aren't supposed to happen.
Yeah. And so that's a really important thing. It's just when we give these medications, HIV, like many other viruses, can mutate, and the mutations become problematic, and then we kind of go down a list of types of drugs, and then we eventually get to tenofovir.
Mhm.
It's like the last drug we can use, and if you don't take that appropriately, it's going to affect you. I think the patient that we had at this time, her CD count was over less than 30 at the time, and they just weren't compliant for multiple personal reasons, but
Or adherent.
and that was because they didn't like the color change of the drug. From
Oh,
the,
that. Oh my gosh. I
That's the
forgot
one you're talking about.
yeah. So that was the story.
Okay.
Y'all forgot it.
Insurance had to change it to a generic, and the generic was orange, and it used to be white or something. And
Patient said she will not take the drug.
this is something you will not learn in a classroom. It is a real life. What the heck is just going on in front of me? Yeah.
Yeah, it was like it confuses you. It's like, really, the color, that was an issue. Like, a lot of these individuals are dealing with some mental issues and just some preferences, and we can't really just look at them as a patient that we're treating just as a family medicine practitioner or student. We kind of have to look at them holistically as like the mental aspect of what they're going through, because a lot of them also see these psych physician.
And the methadone clinic, they all
next
come
door.
right across from the methadone clinic.
There's a lot of substance abuse.
Yeah, substance abuse, definitely.
Yes, there's a lot of comorbid conditions going on.
Mhm.
Yeah.
You read their charts, and it's not just they're coming in for HIV or hepatitis C or sometimes pain.
Pain, yeah.
So you brought up methadone clinic. That's a good
Mhm.
point. There is one next door to the HIV clinic we've been working at,
Mhm.
and a really cool thing that we saw happening was we went there, and the HIV clinic partnered with them because apparently, like we said, 800,000 people in New York are walking around HCV positive. They don't even know it, and there is a significant substance abuse problem in these parts.
Yep.
So when people do go to those methadone programs to seek, very valid help, they're doing a good thing there. People have the chance to piggyback an HCV diagnosis or a screening test, and if appropriate, treatment when they're already getting doses of whatever they might be getting at the programs. So it's pretty helpful.
And I think Dr. Perry was telling us it's around 320 patients in the methadone clinic that have been untreated with Hep C.
Soon to be overlapped with his clinic. Right?
Exactly.
Yeah, that's good.
Yeah. And could y'all discuss some more about the group therapy session, the pros and the cons of it, and some of your experiences that we had last week?
Oh, the Wednesday group?
Mm-hmm.
I thought it was really good.
Mhm.
It was very unique. It was reminiscent sort of like a an AA type style meeting where people that were pre-treatment, people that were mid-treatment, and people that were post-treatment cured status for however many trials or failed attempts they had to get cured, all kind of went to a lecture. And donuts bring lots of people for lots of things.
And bagels.
Yeah, bagels. Went to a lecture for round carbs and listened to us talk about, Hep C, new treatment options, new drugs, new opportunities, and then those patients networked with each other, talked to them, and then after that we debriefed with all of them, and the ones that were starting the treatment took their first dose with us in the clinic, and we set them on their way for what was hopefully a good adherent schedule. So I thought it was really good.
Yeah, and the way they organized it was there were a couple of people that were cured, a couple of people that are intermediate within their medications, and people, like you said, were just starting the medication.
Yeah.
And the people that were cured were definitely just giving their positive vibes towards new
best
people starting.
salesman.
Exactly, they were the best salesmen. They're like, yeah, don't worry about it. We went through this, and we know how you feel. And I felt like everyone in the room just felt awed at how amazing these people are at curing and spreading the message.
Yeah, it was like they're spreading the gospel of
Exactly, I was gonna say that.
Yeah, because there seemed to be a little reluctance from some people who had been treated in the past unsuccessfully, and where did that come from?
So that's a double-edged sword, and I fall into this category too, because it's not an ignorance thing, but a lack of exposure and knowledge thing. So a lot of people, like we just talked about a minute ago, think HCV is a death sentence. Oh, my uncle died of hepatitis. Oh, HCV is AIDS. My girlfriend won't have sex with me. It's the end of the line for a lot of people. Mistakenly so. It's curable. It's treatable. But also on the other end, when they go seek care at other physicians' offices, they might not be as knowledgeable about this stuff. So they'll order repeat Hep C antibodies, and they'll come back positive. And they'll go through the whole spiel with them about how they're HCV positive and they have risk stuff, and they'll talk to them about the wrong things that day when they could be on week 9 of Maverick therapy, and be almost cured.
Yeah.
Or they might go into physicians' offices and they might not explain what a test is going to be doing. A lot of the questions we had at the end of that group session were about, what do these tests really mean? How do they know what it is? And I was happy to tap into my knowledge to explain some of that stuff, but it's not easy when not all of us on our side with the white coats know the whole story.
Yeah, this is like a small micro niche inside of family medicine and internal. And it seems like along with that, some of these people had PTSD from the treatment that they got in the past.
Yeah. You're right.
And why is that? What was going on back then that doesn't really happen as much now?
So you're talking about ribavirin and interferon, right? Back in the days when they had crazy side effects, bone marrow suppression, GI problems, diarrhea.
Old school.
Yeah, a lot of problems with it, and the cure rate I think at that time was less than 50% with the medication.
Yeah, so it's like flipping a coin, really.
Exactly, exactly.
And you're taking this medication for not just the 3 months max that you with the new medication. You're taking 6 months to a year, and then you have to wait He said 2 years to find out if
follow up
this person was actually cured. So now that can all happen within a short period of time.
8 to 12 weeks, right?
Yeah.
I'd like to reassure our listeners that nobody here is being paid by a pharmaceutical company, and we're not trying to promote any drugs.
Thank you for that, Ahmed. What are you doing later? Going to dinner?
Yeah.
All right. Well, that kind of wraps up our experience. But I want you guys to kind of leave our listeners with something, inspirational, just your personal spiel before we go.
So, cool thing about this, and what I hope you'll include in a lot of your podcasts about this is, this is just one rotation. This was our first rotation, and this was hit the ground running. We didn't have time. I don't think our attending ever really learned our name properly. We just introduced ourselves and got just working and rolled up our sleeves and started meeting patients and doing this good stuff and learning a lot. But I knew none of this before coming here from school. This was you learn it trial by fire. Yeah. None of us are holding notes right now. None of us are reading anything. We are literally talking about drugs and stuff that we experienced. So for that's worthy of comment on rotations.
And I'd like to give a shout out to Dr. Perry. I mean, our attending. He has just made these last 4 weeks exceptionally amazing. I mean, like Aki said, when we walked in and we had no clue or no information of what's going to happen from 4 weeks from here and out. Now we have all this information and a good memory that's going to be carried with us, I think, throughout our whole life.
And depending on where we go in our future professions, I think we can use a lot of the things that we're learning now as medical students. And before we leave, we want to talk about kind of what spawned this specific podcast. And
Pinnacle moment.
The pinnacle moment for us is most of the time when we call a lot of people, and when we're calling them, we don't really have good news. But there was one time, well, a couple times that we had good news, and Dr. Perry likes us to do something that we probably won't get the opportunity to do very often, and that is to call people to tell them that they're cured. Right? We told you that hepatitis C is kind of looked at as a death sentence for a lot of these people, and some of these people, when they are cured, they don't believe it. Right? They don't believe that, hey, I'm going to take these drugs for 8 weeks and I'm going to be cured, because they might have done the whole interferon cocktail in the past and went through hell, and it didn't work for them. So now, when they get to now and they find out that, hey, we're going to call them 6 months after, or what's the time period after their last treatment they would call them?
16 weeks.
16 weeks. So 16 weeks after the end of their treatment, we test their blood again, and if it comes out that their viral load is still 0, still suppressed.
Done.
What does that mean?
Cured.
Done.
That means
Done, and done.
Exactly. We're done. We're cured. And we're done today. All right. Have a beautiful day, and thank you for taking the time to listen to our podcast. Take care.
Thank you.
Woo.